You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Behrens, welcome to the Nailed It Ortho Podcast. We are happy to have you on, and I'm looking forward to this talk for the day. So welcome to the podcast.
Thank you for having me. Really appreciate it. Happy to be here.
Yeah, and we were talking a little bit before we got on air about kind of a little bit about your story and how you got into where you're at now in your journey. So typically at the beginning of our podcast, we ask our guests a couple of questions, just getting to know them. And so one of the questions is can you kind of, tell us about the story of what brought you to where you're at now, and then why you chose your type of practice that you're in?
So my story is had a little bit of a circuitous route. As we discussed, I did residency at Brown in Providence, and the way it's set up there, it was set up by James Herndon back probably, 20 or so years ago, 20, maybe even more. He was a chairman at Pitt, Harvard, and Brown. And what he did to all the programs, what he thought was useful, was incorporating this sixth year, which was a trauma year, where you were kind of we call them super chiefs, but junior attendings. And some of them have morphed into 6 months of research, 6 months of trauma. I think they do that at Pitt. Some of them have gone away. I don't know if even Harvard has it. Maybe they have a research year. But at Brown, they still had this sixth year, which was a gift of Herndon. And it, I think, set Brown apart as a residency and was one of the reasons why I wanted to go there. But it probably also scared off, if that's the right word, some people who maybe weren't so interested in trauma or, looked at it as an extra year that, we spend enough years training and they kind of just wanted to be done and go on to the fellowship of their choice. I felt that was sort of one of the best years of my training. So we did that trauma year after residency, and you're a junior attending. You have all the responsibilities of attending, but you have the phone a friend backup, if you need it, which you often don't have, when you get into practice. So that was really helpful. And I think when you finish there, you sort of, you graduate with kind of a level of confidence that you might not have otherwise, which I thought was beneficial, and one of the reasons I really loved the training. I went from there and had an interest in sports, really enjoyed the injuries, really enjoyed more of the minimally invasive, elective, get people back to doing things at a high level, career. And then, did sports at Pitt for that reason. Was in practice for a few years doing sports and a little bit of trauma because I do love trauma. I wanted to keep that as a part of my practice, and kind of felt, and I joined a private practice at first, mostly because I wanted to move close to home, and my home was New York and, towards the tri-state area, like Manhattan and Long Island area. So the practices there are, or rather the competition there is such that, there's not an incredible amount of job opportunities in orthopedics, especially in sports. So took up a job at a private practice, kind of found myself, I don't want to say floundering, but sort of finding it hard to find direction, because you end up being, I was telling you, you kind of like the jack of all trades, master of none. And, I thought it would be hard to sort of develop a particular academic interest with the ability to do research, carry that forward, and become kind of like the person for a specific pathology or pathologies. And was kind of afraid of what my career would look like in 10, 20 years. And then the same time was kind of missing foot and ankle surgery, because I had a incredible mentor in residency. His name is Chris Giovanni. He's at MGH now, was at Brown for a while. His passion for foot and ankle and sort of the ability to kind of focus on trauma, sports, reconstruction, a little bit of pediatrics, deformity. Yeah. I felt like everything, in one. And I missed that. And I felt like I, would prefer that as a future than the career in sports with team coverage and all these other things that didn't interest me as much as I felt that it interests other people, like kind of being on the sidelines and, taking care of athletes to that degree. So ended up being in practice for 3 years, was board eligible at the time, actually taking part 2 of the board, which is the oral part, like you guys know. And then went to do a, third fellowship, which, I think we discussed briefly before, but it creates a little challenge because, you're a resident, you're looking forward to finishing, then you're a fellow, and then you're attending, you're financially feeling like finally, I'm able to, afford some things now, and maybe looking to a future of buying a home or all these things. And you're like, oh, maybe I'm going to do a fellowship, so it creates a set of financial challenges. It creates, some family challenges. If your significant other or your family is now realizes they have to, quote unquote, lose you for a little bit more time to be a student again. And then it kind of creates like sort of a little bit of an intellectual, and I don't know what the right word is, challenge, because just from going to, we're always students, but going really from a student, just kind of like a teacher, to now a student again, can be humbling. But, I didn't really look at it that way. I kind of looked at it as, it was going to get me to where I wanted to be in 10, 20 years. I had a passion for it, and I wasn't gonna treat it as a, oh, I know more than you do kind of thing. I was there to learn, and kind of go to the fellowship that was going to give me the best opportunity to learn as much as I could about anything and everything foot and ankle. So I did a year in Charlotte, by far my best year of training, both from an academic standpoint and just relationships that I formed. And I think if I could give any advice, to all of us that are anyone listening in training, which is most of you, it's important to find, like-minded, good mentors that are, willing to spend time with you, willing to kind of talk to you about everything, not even only things that are orthopedic, just kind of outside of life things. And I think that's very important. I think we don't have that enough in I'm sure a lot of people say this about their respective careers, but we don't have it enough, definitely in medicine, especially in orthopedics. So it's nice when you find those people that really you can turn to for advice and for mentorship, and then they become, your friends and people that you have these relationships for years. So that's what I've met people all along the way, and I can say that in different parts of my career, but I think, or I know what Charlotte afforded me was that mostly, and direction. So, I'm really appreciative of that. And it was definitely the best year. And from there, I had that private practice job and kind of missed foot and ankle. I missed academics, and ended up getting a job at Hospital of Special Surgery in New York. And this is where I've been since 2018 or late 2018. So a little bit of a circuitous journey, but happy where I'm at.
Yeah, I think, everybody has their own journey, own story of how they end up to where they are. And, and everybody, I think at the end of the day, does what's right for them. And I just had a quick follow-up question to that. What is, if there are any, major differences, what are some of the differences that you've noted between working with private practice and now, working being at HSS for X amount of years, for the past couple of years?
I think one of the main differences is really the focus on education. And, that's multifaceted, obviously, but, it starts with, first of all, like accountability and kind of, you're fixing an ankle fracture, for example, keeping it close to home in the foot ankle world, fixing an ankle fracture. And, now that case is going to be presented at tomorrow's conference, and it's going to be analyzed by, few surgeons to be on the call or the Zoom these days, or even in person that are more senior than you, that have done like hundreds and thousands more than you. And they're going to be looking at those X-rays. So you making sure, and you kind of being confident, and you're being accountable to doing great job, the best job that you can do. And being willing to learn from your mistakes, and willing to get better, and willing to acknowledge that there are likely people that are better than you at it, and trying to always strive to be the best that you can be. So that's, I think, one of the things that academics affords, at least good academic programs, affords the ability for accountability in everybody, and people striving for greatness, and not accepting anything less. With that comes resident and fellow, medical student, PA, nurse practitioner, fill in the blank student, that setting of hanging out with now I don't want to say young, because not everyone's young, but like the young, the hungry, the people that are trying to learn, the people that are keeping you on your toes. You're constantly trying to be the best at what you do, kind of a similar theme, and with and changing with the times, kind of learning, always learning and sort of evolving, so you can teach the new generations the old techniques that work well and the new techniques that may work better, and having kind of the full armamentarium of things to fall back on. So education, I think, is something that is a huge difference between private and academic. And it's not that we all don't want to learn and we're not reading and we're not trying to get better, but there's just more of a push to it in academics. And if you enjoy teaching, you definitely lose that in private practice, whereas there's like endless opportunities in academics. And I guess thirdly, well, maybe secondly, because education was one, but research, like if I think kind of goes hand in hand with the academics, but if you're interested in research, if you're interested in participating in some way, it's definitely a lot easier when you have kind of a whole, research arm, division, or the whole framework to get things done. It's a lot harder to do that if you're either not motivated or you're motivated, but you don't feel like you have the right setup. So that's something that, good academic institutions support, that it's harder to do in private practice. So those are some of the differences that I found. And, if you'll realize, I think, if you haven't already, kind of which category you fit into. If you're someone that really enjoys the education piece, the academic piece, well, then you're going to miss it if you go to private practice, for whatever reason, and you're going to, be looking for that. Whereas if you went into academics, you're going to feel like it was the right move. Those are kind of the main things. And and having residents and having fellows, sure, sometimes maybe, the case takes you a little longer to do because you're teaching, or, you're helping a fellow or resident through a case. But, the dividends that are paid when that person's going through the years and now, you took part in that to make them the surgeon that they are, is huge. And plus, like, they're taking care of your patients. And if you're at a good place, they're taking good care of your patients, and you're not doing as much of the, heavy lifting, so to speak, or, you're not answering the call at 2 a.m. if you have a resident that's on call. So there are those benefits that come along. And sort of the way I look at it is that, you're teaching them, you're getting something out of it, both by teaching them and feeling that and and seeing the finished product, but you're also getting the benefit of the avoiding those like 2 a.m. phone calls. And then obviously the residents that were fellows are getting the benefits of the teaching. So, it's a nice setup, and it's something that it's not for everybody. But I think, it's for me, it's the right fit.
Yeah, one thing I've noticed with a lot of the guests that we've had on that have been in the academic position, everybody is very passionate about teaching others and watching kind of that transformation that the student or the fellow or the resident goes through, and something kind of gratifying about that. And I think that's awesome. We need people in academics to teach us, show us how to do things, and show us the right way to do things, and be mentors, just like you said. I know you said you had your mentor before, who's now at MGH, and I think that's great. And kind of just transitioning and switching topics. I know today we're going to talk a little bit. I need where what you went back to fellowship for, a little foot and ankle, and we're going to kind of talk a little bit about fifth metatarsal fractures. And just a quick made up case that I just made up. Dr. Behrens, say for example, you have a 21-year-old male who is a football player. He's a running back. He was referred to your clinic after being seen at an urgent care center. Found to have a fifth metatarsal fracture. They didn't tell you where it was. They just said it was a fifth metatarsal fracture, and he hurts. And after you speak with him a little bit more, you find out, that this patient had some foot pain prior to having this fracture. They were just playing on a painful foot. Before we get all the way into how we treat this and what it is, given the fact that we're talking about fifth metatarsal fractures, I guess in your experience, who gets these? Like, I guess kind of like what's the etiology behind some of the players that get these types of fractures, and what is I guess that's the first question. What's the kind of etiology, and who gets these types of fractures?
Well, the pursuant or similar to the case you described, the fifth metatarsal fractures tend to be common, of course, in the athletes.
Right.
But you do when you're in practice, you will see them in the elderly folk who maybe have some bad bone, or you can see them obviously in the recreational athletes, even someone just walking on the street that kind of just steps the wrong way on a curb. Those are probably more commonly seen in like the private practice, setting. Obviously, if you're a sports doc or foot and ankle doc, you probably get more of the athletes. You also see them in people that are kind of in the military, people training for marathons, things that require kind of high impact / loading, and they're doing it regularly and maybe even more than they're used to doing. So putting extra stress on and micro trauma on their bones. In this situation, they're fifth metatarsal, and then ending up what was a stress fracture now maybe a full on fracture. A lot of primary care docs see it too, and sometimes they send it to you right away, and sometimes you might get it months later after a story like this, where someone came in with some pain and maybe they didn't see anything on an X-ray, and they just kind of said, "Oh, go back to play, and nothing's wrong." Might have been kind of a stress related injury. But most common in athletes, most common in people that are doing this heavy loading and putting extra stress on it.
Yeah, and every time I go and look and read on these fifth metatarsal fractures, whether it be ortho bullets or different different articles or journals, they always talk about different zones of the metatarsal, and I think that's kind of imperative to know those zones, and then later on we can talk about the different mechanisms behind injuries in these zones and how to treat them. But can you quickly kind of just go over what the different zones are of this, of the fifth metatarsal, and kind of, can you go through what these different zones are, how many zones there are, and et cetera?
Yeah. So when we're talking about zones, we're really talking about, the metatarsal base, right? The fifth metatarsal base. And, Borg came up with a classification system based on the anatomic location of where exactly the fracture is in that fifth metatarsal base. So zone 1, which you have up there, or type 1, actually, no, you have the classification with regard to, at least on the screen now, with the radiographic classification, but it might have been on the slide. There you go. So zone 1 fractures are those that are real proximal fractures of the base. They're also known as pseudozones, and it's right there at the tubercle, and often goes into the fifth metatarsal cuboid articulation.
Okay.
In this area, there's a lot of, as you note on your slide, there's a lot of cancellous bone is right in the tuberosity. There's a great blood supply there. The peroneus brevis tendon inserts there. So anywhere where you usually have tendon insertions usually is indicative of a better blood supply. There's also part of the plantar fascia, or the lateral band of it inserts there as well, also indicating some blood supply. And this area, the nice thing about it is that, if it's an area that, because it has a good blood supply, non-unions are uncommon. At least that's the way it's taught. And anecdotally, that's probably true, with the caveat that I do see a lot of zone 1 fractures that go on to non-unions, but are asymptomatic. And I know we'll get to that later, but the zone 1 is something that is proximal to the 4th, 5th articulation. So it's something that's, cuboid 5th metatarsal and proximal. That would be a zone 1 or pseudo-Jones fracture. Okay. Moving on, and more distal, you have zone 2 fracture, this is what we know to be the Jones fracture, the classically referred to. This is at the metaphyseal diaphyseal junction, and by definition goes into the 4th, 5th metatarsal articulation. So anything that goes into the joint there is what we call a Jones, and we think that probably has something to do with the fact that it doesn't heal, maybe because there's that joint fluid lubricating it. Although, I'm not sure how much, I kind of jump on that, because, the 5th into the cuboid also has joint fluid. So I think there's probably more to do, more to it. But this is a relatively, avascular zone, also known as a watershed area, and has thus a higher risk of non-union. I think up to like 30-40% of non-union has been reported
Pretty high.
In this area. Very high compared to the of zone 1 that typically heal, or if maybe don't unite bony, are asymptomatic. So that's zone 2. Moving more distally is zone 3, and this is proximal to that 4th, 5th metaphyseal diaphyseal junction. This is a common area of fractures in athletes, kind of typical to the one you described, where they have some prodromal symptoms. They have a stress fracture, and now there's an acute event where now you fracture through and through. This also has an increased risk of non-union, and also this is kind of an area that tends to be, or an area fractured more commonly in people that have some hindfoot varus or cavovarus foot, or even a Charcot foot, where they have some sensory issues, where they're walking, overloading the lateral part of their foot, and they're stressing the area. Now it goes on to fracture. So while it might not be as avascular as zone 2, it's still kind of a quote unquote high risk stress fracture, one that have a higher tendency of going on to non-unions.
Yeah, and I was going to ask you, or we'll probably get back to it a little bit later, talking about the cavovarus foot and these kind of zone 3 injuries, and talking a little bit about the treatment. But just to summarize what you're saying, so zone 1 is a little bit more proximal to that articulation of the 4th and the 5th. Zone 2 is fractures right through it that go into that joint of the 4th and the 5th, and then zone 3 are going to be distal to that, more towards the toes, or just distal to that articulation. And you mentioned it a couple of times about the watershed area, but can you kind of what is the blood supply to the 5th metatarsal, and I guess what makes this important? Just kind of hammering home this concept.
So you have a nice slide there, and it shows the intermedullary nutrient artery going in there, kind of in the mid shaft area, and then branching proximally and distally. You have these metaphyseal perforations, you have periosteal arteries, but you can see there where these metaphyseal vessels are kind of meeting the intermedullary nutrient artery vessels, where the branches are proximally, and right between there is the watershed area. It's right. That's where you get these Jones fractures, or if you have a quote unquote Jones fracture in that area, you can see how the blood supply comes proximal, comes distal to proximal, but there's an area where there's not much. So where there's an area of poor blood supply, you're going to get an area of higher non-union rate.
Yeah. And we briefly mentioned it earlier. And just in reading, I saw about the kind of this TORG classification. Is this used, or is this is more for just like, reading and knowing purposes? I included it just because I read it and I saw that it was one of the classifications. But are there any other classification systems for fifth metatarsal fractures, or mainly just, knowing the different zones and then knowing kind of the etiologies and then how to treat fractures of those different zones?
Yeah, I mean, this is definitely used in the sense of describing, radiographic characteristics.
Okay.
I think the history. I'm not a huge fan of orthopedic fracture classifications in general. I do think, though, whatever helps you to remember, the kind of bullets, like in this case, zone 2 is in a certain area and that has a higher non-union, and maybe you're going to treat it differently because of that. Okay, well, then I think it's cool that you remember that it's called zone 2. But in general,
Right.
no, I mean, seriously, in general, it's the principles, right, that matter most. And, we try to lump everything into classification systems, and they're valuable if it affects treatment. And I think they're also valuable if you're trying to describe the fracture or dislocation over the phone to your attending, in the middle of the night, or you're talking to an ER doctor and trying to ask him things. If he knew the classification system, that'd be helpful for you to, have a disposition on that patient. So in that way, it's valuable. The radiographic classification kind of clues you in a little bit into the acuity of the fracture. So, the slide you have up there is pretty good. So, you have the type 1 where you have the sclerosis, which is on the, lateral side. The fracture line's narrow. You don't really have any sclerosis, in the intermedullary area as much, right? So this is something that, is telling you there's probably more of an acute fracture there. It might have been on top of stress fracture possibly, but it's more of an acute situation. Then as you kind of go up in the classification where you have a toric type 2, indicative of more of a delayed union, this is a situation where the fracture line is not as narrow, it's wider. You have some intermedullary, sclerosis there. And this is telling you that it's something that's like, it's trying to heal, but it's not quite getting there. Probably because of the blood supply issue, or maybe because the patient wasn't immobilized, or maybe they were, they're walking on it and doing too much, too much impact activities. So, or loading rather. And then, further, you go on to type 3, where, there's a full on non-union, you have, it's wider, intermedullary and on the cortices, and there's like no callus there. Right. So this is something that just really went on to not heal at all. So it kind of tells you really where you're at, with this patient, and was there a prodromal kind of setup here? Was this something that was trying to heal? Is this a biology issue? We already know there's a vascular issue in that area. So how long? This kind of clues you into how long this has been going on, and may help you, determine how you're going to treat it. So, it's more of that. But this is kind of what you would see. This is the classification system in, metatarsal fractures and Jones fractures, but you can kind of translate this to other stress fractures or other fractures in the body, at least with regard to the cortex and the medullary, canal.
Right. So it kind of clues you in towards, what type of injury it is. And just like you're just saying on the radiographs, this is, when you see a non-union somewhere else, it may look very similar on the Xrays, where you have those corticated edges and the medullary canal is blocked. But this I guess TORG is for the fifth metatarsal. This just gives you an idea of how long the injury is been going on for, and what the injury, just like you were just saying, what the biology of the injury is. And we've thrown around this term, the Jones fracture, and maybe we can just do a little quick history lesson. But why is this called the Jones fracture?
So this gentleman, Robert Jones, in the slide there, you kind of show he was around the late or mid 1800s to the early 1900s. He actually, published this classic article, and nicely quoted from it. The fracture of the base of the fifth metatarsal bone by indirect violence. So really, not someone stepping on your foot or hitting you or something like that. Something that occurs indirectly. And maybe he was even suggesting, the stress related fracture, that comes over time. But he described 6 cases, and he actually had one, reportedly while dancing. So it's from him that we kind of get our, nomenclature of that particular fracture. And I think, I haven't read his particular article, but I think through the years we've kind of divided that base area into the zones that we described to better understand the ones that maybe heal better and the ones that go on to maybe give us trouble. But he's kind of at least the first that we know of to specifically define that area as being problematic and an area that fractures.
Yeah. And I just thought it was cool. I was reading on it. I was like, oh, he was dancing, sustained a fracture. I feel like for med students or early residents early on in their foot and ankle rotation, it may be a good quote unquote pimp question that they may get asked. So this may get somebody some browning points. I'm not sure. But anywho, continuing on and kind of moving forward and kind of talking a little bit about the history and the mechanism. I know we kind of already spoke already and said, this could be due to an acute traumatic event, or it can be due to kind of this chronic, patient may have a stress fracture or a stress reaction, which then turns into a full-blown fracture. But I thought what we can do as far as, talking about these different zones and the history and kind of how the mechanism of injury is differ in these different zone injuries, from kind of zone 1 to zone 3. So can we, what are some things that are possible things that we should just know or be on the lookout for when we're talking to these patients, trying to elicit a history and figure out the mechanism of these different types of injuries for these different zones?
Yeah. So again, like, pursuant to my hatred of classification systems, the way I kind of remember, or at least started to remember it, because you never know. You're like zone 1, zone 2, zone 3. Well, is zone 3 proximal and zone 1 is distal? At least when you're kind of first learning, to help you remember. I mean, the peroneus brevis inserts on the tip, on a tuberosity there, right? So what would put that tendon on stretch? This is the way I think about it, right? And so you put that tendon on stretch, you're more likely to have kind of an avulsion type injury. And to do that, it's plantar flexion and inversion of the hind foot. So that's why when you have forefoot supination, plantar flexion, and you mentioned there your lateral band of your plantar fascia inserts there too, but your brevis is under tension, and that overpowers the bone there and avulses a piece of bone. And because it inserts laterally, the brevis, that is, the fractures tend to begin laterally, and then they extend more proximally, either proximal to the metatarsal cuboid joint or through the metatarsal cuboid joint.
Okay.
In zone 2, this is kind of an area, again, in a watershed zone. Again, the fracture begins laterally and extends, medially. Unfortunately, sometimes through the 4th, 5th, metatarsal diaphyseal articulation. And this occurs with the, forefoot, really with, I think, forefoot adduction, which is what it does. So you often see these injuries, kind of on the football field where the foot's planted and the body kind of goes lateral, but the foot stays planted. So essentially it adducts and it cracks, right? Okay. In that, watershed zone. And this is also, kind of an acute injury. So zone 1 and 2 are really these acute mechanisms.
Okay. And then what about for our zone 3 injuries, or these, I guess, more diaphyseal type injuries?
Right. So these are more distal to the zone 2. So distal to the 4th, 5th. And I keep saying 4th, 5th because, on an X-ray, easy, right? The fracture line, if you see the fracture line going into the fourth, fifth articulation, that's by definition a Jones. If it's distal, just distal to that, it's a zone 3. If it's just proximal to that, wherever it is, it's a zone 1, right? So
Correct.
In zone 3, like you said, this is, from the stress related microtrauma, repetitive microtrauma, where you're constantly loading. This is the fracture that occurs on the people that have the malalignment, which we can talk about a little later. But this is the things these are the fractures that occur. People that have the prodromal symptoms, again, like they, and they have a higher non-union rate. They're slow to heal, like you mentioned there.
Yeah. And we briefly touched on it before, but so, a patient comes into our clinic, they don't have any Xrays, they were just told they have this fracture. What films are you getting just to, cover your basis for, these fractures?
Right. So someone that, described an injury or similar to the football player that you mentioned, has this lateral foot pain, been going on for a while. Whether they report an injury or not, they're going to get, at least in my, office, they're going to get weight bearing foot X-rays, 3 views of the foot. So, in this case, we're looking obviously at the 5th metatarsal. The AP is really an oblique of the 5th metatarsal. A good oblique of the foot really shows you a good AP of the 5th metatarsal. And if you look closely here, maybe harder to see on the AP here, but you can see a little bit of something going on laterally on the cortex and the AP, but not really sure that much until you look at the oblique, where you can see that, kind of quote unquote dreaded black line, kind of coming laterally there. And I'd say, this is sort of borderline, but maybe, more of a Jones, but borderline meaning zone 2, zone 3, right? So
right,
depending on where that fracture is going medially, which I can't tell, at least on my computer now, but it looks like it might be going into the 4th, 5th. But this I would probably call a Jones, and classically sometimes these tend to have more plantar involvement, which is really a kind of an ominous sign when you have that, because these are the ones that go on to more of the non-unions. But you can see the plantar fracture line there, maybe not so much, but these can end up being some plantar gapping. But this looks like, to me, a stress related issue that has gone through and through, or is about to go through and through. But the nice thing about the reason I mentioned weight bearing, the views are they're not useless, but there's so much more use in getting weight bearing X-rays when you can in foot and ankle. It tells you so much more, mostly about the biomechanics and the loading condition of the foot, the position of the foot when loaded, rather. And you can see this on the lateral. This person's foot, it looks actually relatively, maybe slightly cavus, or at least or neutral with this X-ray. But you can draw lines from Murray's line and kind of see where at the position of the foot. So very important to get weight bearing X-rays.
Yeah, and you took the question out of my mouth. That was literally what I was about to ask you, and you answered it. So I think that was a great job that you did that. And so, in your practice, is there any role for getting a CT scan or an MRI in any of these patients?
I think there's some use in getting an MRI if maybe you're not certain there's a fracture, or you're not certain, maybe you have a suspicion that that's a stress related injury. Maybe you got a radiograph that didn't show anything, or a bone scan that was equivocal or something, and you'll see it there on the MRI. It's probably the gold standard for or at least a high negative predictive value. If nothing there, it's probably nothing there, right?
Right.
So you would expect to see some high signal and edema there, on an MRI. So that would be my reason to get it. Maybe your suspicion. The CAT scan I rarely get. I think it may be useful, if you have a patient that, you're trying to say if it's a delayed or non-union, you fixed it, you want to see how much it's healed in that situation, or you're making a decision on return to play, high level athlete, and you want to get a CAT scan showing it's fully healed. There are some people that do that. I think that's maybe falling a little bit out of favor recently, where we're having a little bit more confidence in our fixation, more confidence in, history of how it's feeling to the patient, maybe protecting them in some ways that maybe people aren't waiting to get a CAT scan. The classic teaching when I was a resident was, you want a CT scan showing it's fully healed before you let them go back to play. Not necessarily, where we're at now, but you can get it to, kind of evaluate how much it's healed, kind of in a 3-dimensional way.
Yeah. Is that a thing where it's like, if it's greater than 70% healed, or does it like 99% all the way healed? Is there a parameter, just since you mentioned it?
It was more of like a fully healed, ready to go. If it's not fully healed, not really. But from talking to a lot of the team docs, it's really, a symptom thing and an X-ray evaluation, reserving CT scan for kind of the questionable, ones.
Okay. And just moving forward. So, we've seen this patient, we've gotten X-rays, we've diagnosed them with, a fifth metatarsal fracture, and, there are different treatment options for different zones and different types. But which of these fractures are you treating non-operatively? And then what is your non-operative treatment regimen?
I mean, so there's a role really for non-operative, treatment in all of them, depending on, the patient, what's their activity level, are they a high level athlete, or are they, an 85-year-old who's pretty sedentary? There's that with just walking, maybe has bad bone quality and fractured. So there's a role for non-operative treatment in all patients. I would say, however, that, you can pretty confidently treat pretty much all patients non-operatively, with, non-displaced zone 1 fractures, and even ones that are mildly displaced, because a lot of them heal, and a lot of them heal by 6 weeks, 2 months. You might in some of these patients get some situations where you don't have bony union and you have these fibrous unions, but if you do have it, they're typically asymptomatic, and if of those you need to fit to address, the fixing of the situation isn't too challenging. So definitely we treat more zone 1 fractures non-operatively, and this is really just protective weight bearing in either a boot or a shoe. That's typically fine. They're stable fractures. And then, there's this question, the classic teaching was, you have a zone kind of 2 fracture, or zone 3 fracture. These are, kind of high risk fractures. So maybe we want to, non-weight bear them. And the way I was taught, you non-weight bear people in a short leg cast for 6 weeks, 8 weeks. I mean, it's pretty morbid, especially even in an older person who's not an athlete. Now you're setting them up for maybe, DVT, possibly, or increasing their risk at least. These definitely have a higher non-union rate. So the thought was that we'll keep them immobilized, and that'll help. But I think more people are not casting them. I don't. At most, they'll be in a boot, and potentially, depending on their activity level, age, they might be protected weight bearing or non-weight bearing. But I think people are moving towards, protected weight bearing, in a boot, for those ones that you're not going to fix. But as you see on the slide there, and that's pretty accurate, some of these can require, 5 months, for these zone 3 fractures to heal. I mean, that's unacceptable, for pretty much everybody, right? Unless you're non-ambulatory, you're 5 months, immobilized, maybe, not walking on it for a while. I mean, that's That's
a long
your
time.
life. It's a long time. So, that can't be the solution, right? I mean, if that's the solution, non-operative, then, most of us would elect to fix or even have one fixed if we had it ourselves. So.
Yeah. And I saw, well, at least when I was reading one of these articles, they had these little like metatarsal functional braces I had never seen before reading this article. I don't know if is this something that, have you ever seen this used? Is it still used, or was this more like of a historical, educational, like, this is also an option?
I've never seen one, read about them.
Great.
I've never used one. I mean, I don't know. I mean, I guess the only benefit of this verse, I'm in looking at it, right? Like, it might be hard to get a shoe on over that, but that would be my only thought as to why it would be better than a hard sole shoe, because, you can walk in both. This is pretty cumbersome. And even if you can get a shoe on it, I'm assuming it's not that comfortable. So, I don't know. I don't see, I see if I had to wear that versus a hard sole shoe, I'd probably choose a hard sole shoe. So that's pretty much my go-to for these ones that I'm going to treat non-operatively. It's a hard sole shoe for the most part.
And those you still have is just protected weight bearing. You don't have any of them non-weight bearing, like even your zone 2s, you still have them protected.
I mean, it depends. I think if in an older person, for sure, yes. In a younger person, if they're very active, I might want to slow them down a bit. I might, keep them off of it for a few weeks, or fix it. But someone who's older, I really try not to have them non-weight bearing, because I think it really increases the morbidity of it and other things happening. Really, you really try my best to keep, I say elderly, but older people weight bearing. Yeah, moving.
And that being said, on the opposite side of this, now we're talking about the operative treatment, which we all love to operate. This is orthopedic surgery. So I guess one of the ways I was thinking we could kind of split this up would be, I know we hate the classification system, but let's just say, I'll just say proximal, these fractures that are proximal to the fourth and fifth articulation. The zone proximal to the fourth and fifth articulations. What are the operative indications for fixing these? I read, there are different numbers on different things that I read, but I don't know if there's a general consensus about it, but what are the operative indications to fix zone 1 fractures? And then what are some of the options?
So yeah, no, I shouldn't have said the word hate. I mean, it's not that I absolutely hate them. I mean, whatever helps you to remember things. I mean, I just think it's more important to learn, the concepts,
right. I agree.
As to, and why something, what are the biomechanics behind it. And if you understand the principles and the concepts, you're not going to forget things. Classification systems are easy to forget, because they're just not random numbers. And, if you don't know, the why and the how, then you kind of lose the, you lose the value of it. With regard to fixing zone 1 fractures, I mean, I've definitely fixed them, for sure. Displacement, I mean, greater than 3 millimeters here. I mean, that's not an exact number. I mean, I think that I've surely not fixed ones that were displaced 3 millimeters. I've probably not fixed ones that were 5 millimeters. Right. I think sort of there is a gray zone here. And I think some of it also is related to the patient, right? So again, what patient are we talking about? Very active, middle-aged, older, what they're, what are they doing? What are they trying to get back to? So that's definitely, probably the most important question. The ones that are completely extra-articular to the, cuboid joint, those probably can get away with, more displacement. The ones that kind of go into the joint and are displaced, I probably have a tendency towards fixing them if they were, call it 5 millimeters. I think the comminuted ones are, this particular site says fix them. If I had a comminuted fracture that was non-displaced, or a comminuted fracture that was displaced a couple of millimeters, I probably wouldn't fix it, because I think they're challenging to fix perfectly, they probably will do well if they heal bony or if they, have a fibrous union. And if they don't, I can easily handle that later, right? Because the treatment for zone 1 fractures here, I mean, you have a picture of it fixed with, kind of a screw and tension band, construct. Sometimes they're not amenable to a screw. Maybe the piece is really small. You can't really put a screw in it. You can't really put a tension band in it. So the treatment would be take the piece out and, tack the brevis, peroneus brevis tendon down. Well, that's the same treatment that you would do if it didn't heal and it bothered the person. So you're not really burning bridges, if you don't, fix some of these, and you might, get more to heal that you might otherwise have operated on. So, if it's really displaced in an active person, then I would operate, but I tend towards non-operative treatment of the zone 1s if possible.
Okay. And I think that was a good summary for our zone 1s, but now the meat of it, I guess, would be our zone 2 and 3s. But so for your zone 2 or your true Jones fractures that go into the articulation of the 4th and the 5th metatarsal, what are your operative indications for those? And then in a bit, we can talk about, I guess, different techniques and why you use different screws and screw sizes and whatnot. But what are your operative indications?
Yeah, so I think it's correct, on the slide saying, any displaced fracture, in a active person. I'll keep the, non-active or non-ambulatory or elderly, kind of out of it. But otherwise, if it's displaced, it's a high risk of non-union. I think it's reasonable to fix it. Especially, if it's acute. And that goes for definitely the situations where it's like a stress related, injury that now fractured through and through. In an acute situation, you show here is less consensus. It's definitely true. There's been some studies showing that, in the athletes, you can get them back to sports a few weeks quicker. In the non-athletes, it probably heals quicker when you fix it. I mean, the fixation is typically with an intermedullary screw. And if you do it right, it's a pretty relatively straightforward procedure. And if you can, chop off a few weeks of recovery time, get them back to work or sport quicker, I think it's reasonable to fix these. And then, you avoid the situation of a delayed or a non-union. So I think from a time perspective, and the fact that it's a relatively straightforward procedure in the right hands, these, considering to fix these, it would be my preference, or I would err towards fixing them in the, in the healthy active patient.
Right. Yeah. That's pretty much right along with what I read. And again, in that healthy active patient, or in like, the athlete that comes in, with these types of injuries, those would be ones that you would probably fix. And then for your, this is exactly what I was just saying, but for your zone 3s, for you, what are your, your indications to fix those?
So, these are obviously two different patients that you have up there.
Right.
And I can criticize these X-rays a bit, but
yeah.
The X-ray on the left with the right foot, I'm not sure where the original, fracture was, but presumably it was a little bit more proximal than the one on the and then the middle image and the middle image that looks like it was fixed on the right of the screen. There are a few issues with all of these X-rays, but just pointing out that the middle one, that technically the zone 1, 2, and 3 are for the base area, right? And I guess you could call that a zone 3, but it's really a shaft fracture. Okay. And there's some teachings that would say never fix the 5th metatarsal shaft fracture. I don't really ever use like ever, always and never, but there are some people that will say that, like, no, you never have to fix an acute like shaft fracture, which this looks like. This particular fracture, actually, I might have treated, non-operatively. in that image, unless potentially it was a professional high level athlete that I'm trying to get back quicker. But, I've treated a lot of those fractures at the middle image, weight bearing as tolerated in a hard sole shoe, and they do just fine and heal the fracture just fine. Not undergoing the surgery on the right. But yeah, I mean, that's pretty much my gestalt. You often, the screw, while that screw is not perfectly placed and it's too long and, might even be, presumably is in the bone, but it's definitely too long. That one was probably for a Jones, and, that would be my go-to fixation for a Jones or a proximal third metatarsal. But I probably would usually not fix that middle image.
So if you have a patient and they have, you have a young athlete and they have that Jones fracture is displaced and you decide to fix it, what is your proposed, I guess your technique? Do you do percutaneous? I know there are a lot of different techniques, some tension band, or some talk about putting a plantar plate that I've seen in different studies. And then what size screw you choose? Do you choose cannulated versus fully versus solid screws? What can you kind of give us a rundown on, just some of the technical tips?
So, my first step. So if I have a zone 2 or 3 fracture that I'm going to fix, my go-to is usually a intramedullary screw that's not cannulated, that's solid. With regard to technique, I'm doing a screw. What do I do, or how do I proceed? My first step in these procedures, really, I use the fluoro machine basically as a table, as the OR table, and I get a perfect images and draw out the exact trajectory of the screw where I want it to be, on both the oblique and the lateral. I make sure that, quote unquote, high and tight. So, medial enough, and high enough that I have the right trajectory. Draw those lines, and where they intersect, go about, centimeter proximal or half centimeter proximal, make a little incision, and, spread, down to bone, making sure that, I'm avoiding sural nerve branches, peroneus, brevis, and, finding the spot, as opposed to just kind of like, perking it in there. Make a little incision where you kind of drew your perfect lines. And then being really, meticulous and careful about, that K-wire insertion, and direction, because that's the whole case. Honestly, like you get that trajectory, you get it on point, like the first shot, it's a sawbones after that. It's a really an easy case, but that's the most technically challenging part of the case, getting perfect imaging, getting perfect trajectory, getting perfect starting point, on position of that K-wire. So you get that K-wire position, perfectly down the shaft. If you look at that image on the right of the screen, I would say that, well, first of all, the screw's, quite buried. And it looks like a solid screw, which is good, but there's a few issues. One, it's buried, which can be very hard to get out. If you have to go back, you have a non-union, you need to get a screw out. So I would not bury screws. I would, keep them, on the cortex. Secondly, they might have, lagged by technique here. But, you have a fracture that you want to compress, and they put a fully threaded screw in here. You want to, right. You want to avoid doing that. You use a partially threaded screw. Pretty much we all use partially threaded screws, but, if they over drilled the fracture up into that point, then I can't criticize them that much. That's fine. But, I don't know if they did that. But this would be like the worst thing to do, is just put a solid screw across it. and not, not do that, then you're just kind of fixing the displacement, or, you're not compressing anything across the fracture site. And then, you want to try to get the screw as big as you can, right? So to fill the canal, how do you do that? Well, you have the K-wire in there, you over drill the K-wire with a drill bit. And then you tap sequentially, right? You start with a 4-5 tap. And, you kind of see how that fills both radiographically and feel. Are you, with every turn of the tap, do you see the foot move? Do you see the foot kind of, because so you can imagine, let's say you're working on the right foot, and you're screwing the tap clockwise, and then you see kind of the bone torquing. Well, probably has a good cortical fit, right? And then you put that, kind of tap in, either you measure sort of the distance that you want your screw to be, keeping in mind that you want all the threads to be across the fracture, right? So because if you do that, then you're going to get compression. If the threads are crossing the fracture, then you're not going to get compression, which is what you want to avoid. So you want to choose a long enough screw that the threads are across the fracture, the biggest diameter screw that you can to have good strength and fit, and a short enough screw. So like this screw is too long, right? You can see how it's hitting the cortex both on the oblique there and the lateral. You want the screw to be way shorter than this, right? So threads across the fracture, and screw that goes only to the point where the metatarsal is straight and not where it starts curving laterally there. As you can see how that metatarsal has a little bit of a curve. You don't want to put a straight, really stiff screw in a bone that's curved, because you're gonna displace the fracture, right, when it hits the cortex. Right. And also you can actually penetrate the wall there, the medial wall, which would be bad too, right? And you have a kind of a stress point. So you don't want to do that. So those are just some tidbits.
So why, and you're saying, so one of the things you said was high and tight. Why do you want the screw to be high? Is that just the best bone, like just the best bony contact, or why do you want the screw to be high and tight?
No, it's the best screw trajectory, right?
Oh, so the best screw trajectory.
Yeah. So this one, you can see it's not, it's definitely not tight against the cuboid there, right? It's actually, looks like it's too lateral, right? So it's aiming too medial. If you started the screw a little bit more medial here, you would have had the better trajectory of aiming a little bit more lateral. So you avoid abutting the medial cortex and then displacing the fracture, right? Right. And then the same thing, on the lateral, you want it high because, it looks like here it's hitting the dorsal cortex as opposed to kind of being a little bit down the shaft, a little bit more centered. But again, if you, in this case, you would have got away with it probably if you took a shorter screw, because then you wouldn't be hitting the cortex. But in general, close to the fifth metatarsal cuboid, articulation, as that's the tight and the high on the lateral.
And what is the difference between using a cancellous versus versus just using a solid screw?
Well, it's not really a cancellous versus.
I mean, cannulated, or like a non-solid, like a cannulated screw versus using a solid.
More really for strength. So the last thing you want to happen is that screw to break, because if that screw bends or breaks, it is a pain in the butt to get out if the fracture doesn't heal. So you want a screw that you potentially can leave forever and not take out and not worry as much about it breaking. So much harder to break a solid screw than a cannulated screw.
Okay. And you typically just try to fill the canal size up with whatever is, whatever it taps to, whatever can get the best fit. So if it happens to be, a 6.5 screw versus a 4.5 versus a 3.5, you just go with whatever you can get the most cortical fit. Is that right?
Yeah. And usually it's like a 4.5 or 5.5, like a KD, who actually had one of these and had revision surgeries on these. He might have a bigger screw that fits his canal, but, for me, if it was me, it'd probably be a 4.5 or 5.5. And then, the nice thing about that like is that if you go back in, the revision surgery, sometimes it doesn't heal. One thing that you can do, similar to kind of like a tibia fracture non-union, you can do an exchange nail, you can do an exchange screw, and you upsize the screw to a higher diameter.
Yeah. Yeah. And that's, that was actually gonna be the next, before wrap up here in a second, that was going to be the next thing that I asked was any non-union tips. I know I did one of these with one of my attendings, and we ended up using some bone graft to fill the non-union side. So I wonder if that's the thing that you use in your practice, or if you've seen it used, or if you have any other tips besides, of course, opening up the do you open up the non-union side, or do you just ream? That may be another thing to ask you as well.
I've seen it done in a few ways. I mean, you fix it, it doesn't heal. There's a few options. I mean, you can certainly, take, depending on how you fix it, you can take the screw off, rather the screw out, and you can open, bone graft, maybe use some, iliac crest aspirate, some BMAC, some DBM. And then you can put a compression plate on it if you want. My probably approach would typically be, take the screw out, make a small incision at the fracture site, and put some BMAC with some DBM, because there's not much room there. It's kind of usually like it's not like a big gap where you have room for a lot of bone graft. So BMAC combined with DBM tends to be effective, and then upsize the screw and compress across there.
Okay, cool. Yeah, I think those are all good solid tips and different techniques to use to treat these. The
other thing and I've seen, I mean, people put plates on because typically, the area of non-union tends to be lateral and plantar. You get some plantar gapping, and some people think that you put a plate, if you can position it lateral and plantar, that's ideal. And some studies show that there's some pretty good union rates by doing that. The other option, which I haven't seen much, but is certainly a little bit out of the box option, is there's some newer, well, it's not really newer material, but there's some staples that are used in a lot of
I've seen that.
And the amount of compression that you can get in a nitinol, and this is a whole nother talk, but the amount of compression you can get in a nitinol staple, some studies show it's like 50 times the amount of compression that you can get in a lag screw. So
really,
that could be an option too. And I certainly we can consider that in a challenging case for sure.
Yeah, it's very interesting. I'm sure you could have an entire talk on that. And one last thing is post-operatively, is there anything, post-operatively you do a lot on the weight bear? Or do you just keep them immobilized for a short period of time? Anything that you do, for these patients that you do fix?
I probably would, keep them mobilized for a couple of weeks, and off of it, non-weight bearing for a couple of weeks, and then protected weight bearing in a boot, slowly progressing over the next few weeks. That'd be my protocol.
Okay. And if you have a patient that does have, we mentioned a lot earlier in the talk, a patient that has hindfoot varus may, contribute towards leading, having a patient that has, prodromal syndromes, end up having a stress reaction and end up having a stress fracture. So you fix the stress fracture. Do you do anything with the alignment of the foot, or do you rely on your screw and hope that it heals? Is there anything else that you need to do in those cases?
It's tough, right? Because I think, we are, there's a nail and we're a hammer kind of thing. And if we find a problem, we want to fix it. We know that obviously that, cavovarus, hindfoot varus leads to, can lead to more of these lateral overload. I mean, my first step, line is usually not to address that, what people have, like athletes have subtle cavus or some cavovarus deformity. usually my inclination is to fix it and get them appropriate shoe wear, with the appropriate orthotics, either lateral heel wedge, the 4-foot post, things like that you have on here, to hopefully decrease the risk if they have it again. However, if they refracture, now we're going to second surgery or something like that. Well, it's their foot position that caused it, and it's probably their foot position that's not letting it heal. Then we would, consider doing something. The problem is that, with high level athletes, like professional athletes, it's really hard to come back if you have a heel slide. Really, it's not a very well tolerated surgery in professional athletes. So if I were to consider something in like a professional athlete, it might be more of like, if it's a 4-foot driven situation, then we'd consider more of a dorsiflexion, first metatarsal osteotomy. That's better tolerated. But I would try to offload that fifth metatarsal best I could with, orthoses, and, kind of balancing out and making the foot more plantigrade.
Yeah, I think that's good to be able to, number one, notice and then recognize that is a problem. Because sometimes, not sometimes, I could just see how you could have a patient that does have, one of these malaligned feet that ends up having these recurrent injuries. And if that ends up getting missed and not addressed, how that could lead to, just kind of recurrent injuries in the future. And, there are different strategies to manage that. Well, overall, Dr. Behrens, I think this was a great talk. I think I definitely learned a lot about Jones fractures and these fifth metatarsal fractures. Before we wrap up, is there anything else that you want the people to know or take away, or anything else that you think is important to know about these, I guess, kind of these bases of fifth metatarsal fractures?
No, I mean, I think we covered a lot of ground, and didn't really think that I thought, we'd definitely get through this before the time allotted. So I think the fact that we were able to talk about this for over an hour is if anyone listens to this, they must be really interested in fifth metatarsal fractures and foot and ankle. And I guess all, what I would say to people, just a kind of like a word of advice, like when you guys are looking for jobs, looking to see, for careers and stuff, like I said, find good mentors, lean on them, and choose jobs that you're gonna, obviously you want to love what you do and make sure that you're able to do that where you are, but choose being with good people. So make that a high. And sometimes it's hard to know, like sometimes you go to a practice and you're like, oh, this is awesome, I'm in the field that I want to do, I'm gonna it's gonna be high volume, and then you find out that you don't like the people. But put that kind of high on the list of importance, as to get a feel for your partners, or at least if you don't know them, talk to people that know them, because that's going to make a great situation, or it might turn a great pathology situation where you have great pathology that you're treating, and in a bad situation, if you're not working with people that you get on well with. So lean on your mentors, and don't chase the financial piece as much as you chase the work environment and who you're with.
Dr. Behrens, I think that was solid advice for those listening. We want to thank you again so much for coming on the podcast and coming and talking about fifth metatarsal fractures. Again, I think I learned a lot. We always at the end, we always give our guests an opportunity. If you have any social media or anything that you want people to follow you on, or follow you or reach out to you or anything, if you have something great, you could feel free to share it to the folks. If not, that's completely fine as well.
Yeah, I mean, for all y'all, if you guys want to chat about anything, or either orthopedic related, foot and ankle related, need advice, or just want to talk about a challenging case, you can feel free to email me. My website is under my first name, my whole name and HSS, and my email address is my last name, Behrens, Behrns @hss.edu. Feel free to shoot me an email, and we can chat further about anything. Happy to help. And really, appreciate the opportunity to talk to you all today.
Of course. Again, thank you again for being a guest. And those that are listening, thank you for listening to another episode of Nailed It with the podcast. Again, feel free to go ahead and hit that subscribe button and go and leave us a review in Apple or however you listen to this and let us know how much you enjoyed this episode. So until next time.